I'm now on medical treatment. It's on page 976 in your book, and I'm going to start with a surgery called an ORIF. This is a very common surgery, and you will see this acronym ORIF quite frequently in your patient's charts and their history. And I think the best way to explain what an ORIF is just to take what each letter stands for in the acronym and explain what that means. So open reduction with internal fixation is what ORIF stands for. So let's talk about open for a second. Open means it's a surgical repair. So the opposite of open is closed. If someone has a broken bone, and this is your typical child falls off the trampoline, broken bone. I had that happen to my child. And it doesn't break through the skin, it's just your good old-fashioned broken bone, go to the doctor, get a cast on. That's called closed, meaning there's no surgery involved. Um, the the skin wasn't broken by the broken bone, so it's just we're gonna heal it by leaving it closed. Now, if we have like a car accident that's more traumatic, or a broken hip, or if you have a compound fracture, or where all those, it crushes and it makes a whole bunch of little parts, anything like that, or it's extremely out of place, then we have to switch. We can't do that closed non-surgical anymore. We have to do an open, meaning surgical. It's going to require a scalpel and an incision. So that's what the O in ORIF stands for. Basically, it just means a surgeon had to do it with a cutting instrument. That's the most basic way to think of it. Okay, reduction. The term reduction, when we're talking about fractures, means bringing the ends of the bone into alignment. So reduction can either be opened or closed, as we already discussed. Closed would be non-surgical. Oh, I didn't mention traction, which we'll talk more about later on in this lecture, is another form of closed reduction. Or manual pressure, like in the movies when they're out in the wilderness and somebody breaks something, and then the doctor comes and they have them take a shot of whiskey and bite on a stick, and then they put it back in place really quick, and the person just screams. Okay, that's using manual pressure, and it's a lot more impressive when you do that in the movies than in real life. But that would be another type of closed reduction, meaning we're going to bring the broken ends of the bone into alignment without doing it surgically. But in the real world, what normally happens is a surgeon opens people up so they can see what's going on, and instead of just guessing and popping it into place like they do in the movies. So that's what the reduction part of ORIF is. IF, we're going to combine into internal fixation. And I have here Bob the Builder stuff, because whenever I hear the term fix, can we fix it? Yes, we can. Yes, I have children. So we can have internal fixation or external fixation. So you might see in your chart OREF. That means they still had surgery with the open reduction, but they have external fixation. So the main difference is whether the Bob the Builder stuff is underneath the skin or on top of the skin. Usually the more common is the internal fixation. And let's look at our next slide. Okay, so here's some of the stuff that you might see. Now, you're not going to actually see it post-op, but if you went into surgery with the patient and you were watching them have the surgery, this is the kind of stuff that you might see them do. So they make an incision and they're going to do reduction on that bone, meaning straighten it out using all manners of stuff. So here we see some screws or bolts, and here they've used some wire to try to, anyway, there's all kinds of crazy stuff that they can use. This is all sterile stainless steel things, and they go in, and then when they're done, they're going to close up the skin and put staples or whatever in, and so you will never see all of this stuff unless you look on an x-ray or something. So that's internal fixation. Here we have a picture of external fixation. So if your patient had external fixation, you're going to know it when they come back to the floor, because you're going to have all of these little pins sticking out. And so here we still have hardware being used, so he still has screws and bolts and whatever, but it's you can see all of it. And so this is a lot higher risk of infection because you have all of these openings in the skin that could potentially allow bacteria to get in there. So when we have someone with external fixation, we have to be extra meticulous about cleaning these pin sites. So we not only clean their skin, but after we do wound care or dressing care or whatever and clean the skin and the holes in their skin, an additional thing that we have to do is what's called pin care. And usually that just consists of taking an alcohol pad and cleaning each of these pins and cleaning all of this on top to make sure that there's no bacteria on this that could get in through the skin. And so as you see in this little pop-up box here, pin track infection occurs in about 10% of patients with external fixation. And if that seems low to you, it's not. This is a really high rate of infection. And so that's why external fixation is avoided if possible, but there's some cases where it just has to be done. I have very rarely seen external fixation on something like a hip, for instance, or a joint that moves very much, although here it shows it on a wrist. But things that I've seen pins used more on would be, like a femur fracture just right there in the middle or something like that. Casts, splints, and immobilizers, which are found on page 977, listed under common therapeutic measures, but you might think of casting as a way of closed reduction. So open reduction involves surgery and a scalpel of some sort, and closed reduction, we might use a cast, a splint, or an immobilizer. For casting, we're going to put it on wet, usually whatever type of material we're using, and then we have to give it time to dry prior to weight bearing. So for your normal plaster cast, 24 to 72 hours is the appropriate time for drying, and the physician that applies the cast will, or supervises the application of the cast, will specify what type of material is being used so that we know. At the top of the second column on page 977, it talks about fiberglass, which is a different than plaster, and it says fiberglass casts are lighter and have a shorter drying time than the plaster casts, and instead of the 24 to 72 hours, we take that drying time down to 10 to 15 minutes and before the cast can withstand weight bearing. So it says weight bearing 30 minutes after application, so that would be pretty cool. If you go back from where it talks about the fiberglass cast, a few sentences, it talks about a process called peddling. That's just when the edge of the cast is sometimes rough, and one thing that we can do is just to take little pieces of tape and fold them over the cast to prevent the skin irritation from the rough edges. And why they don't call it taping the edge of the cast, I don't know, but for some reason that's called peddling, like think of a flower petal. After a cast is applied, we're going to encourage the patient, or if we're taking care of them, we'll do it, elevate the casted extremity for the first few days related to swelling. This next bullet point here, cast syndrome, I put that on here because students sometimes confuse compartment syndrome with cast syndrome. Cast syndrome is really fairly rare, and if you look at page 978, at those types of casts, we're really only going to see cast syndrome in the body jacket or the spica cast. And that's when you can see that those cover the abdominal area, and so we can have nausea and an abdominal distension, and it's pretty clear to see why. I mean, it's putting pressure. It'd be like wearing a belt that's too tight. So cast syndrome is caused by the compression of a portion of the duodenum, which is, part of your digestive tract, and signs and symptoms would be nausea and abdominal distension. But you're not going to see cast syndrome like with a arm or leg cast. That's just going to be for those full body casts. There's a lot of really important information on that 979 little teaching box there, and a lot of test questions come from that box. Casts need to be kept dry. I remember, I think it's on your exam, there's a choice of putting moist cool, moist compresses on. We wouldn't want to do that because that'll get our cast wet. Even though we want to make it cooler, we don't want it to be moist. We should never remove the padding, or we need to make sure that the client knows that they are not to remove any of the padding either. No foreign objects into the cast, so they don't get to stick a pencil or anything else like that in there to try to scratch. No weight bearing for 48 hours, which we already talked about up here when we said it needs to have time to dry. We'll tell them that sometimes they get directions that they can cover their cast, especially if it's an arm, with like a plastic bread bag or something if they're going to get in the shower. But we need to make sure that they understand that this isn't something they are going to go around with all day long, because it'll trap the heat. And of course we want to keep it cool because that's going to reduce the swelling. So if they are allowed to put plastic over it, if they're going to get wet, we need to make sure that they understand that's for a brief time. And then to report swelling, discoloration, increased pain, burning, or tingling. Traction. For some reason, I really did not get traction when it was taught to me in school back in the 90s. For some reason, I thought it was something that was used like in Little House on the Prairie, turn of the century days. And so when I went to work at Deaconess and I did some work on the ortho floor, excuse me, and I saw, uh-oh, they still use traction. It's not one of those arcane things. So then I started understanding it a little bit better. But yeah, we still use traction, and even though it looks kind of painful, actually the purpose of traction is to relieve pain, and especially pain caused by muscle spasms. The one that I saw the most when I worked ortho was this right here, this Bucks traction. And it's a very short term, prior to surgery type of traction that is sometimes used. So if someone breaks their hip, and a lot of times a broken hip might actually be a femur, but real high up on the femur, so it's in the hip area. But anyway, they break their hip, and for some reason they don't go immediately to surgery. Um, who knows why? Maybe they need to be in traction for a little while to pull the bones apart, or maybe they're on blood thinner and we need to give that time to clear their system, or wait till they're NPO for a while, or whatever reason. A lot of times the surgical repair gets delayed for a few days. And so we might use Bucks traction for that patient. And one thing that's different about Bucks traction than a lot of other types of traction is that it's non-invasive. It sometimes is called skin traction because there's no pins inserted into a bone or anything. Like this one, you can't really tell here, but there's actually bolts that are attaching this thing to this guy's skull. But with Bucks traction, it's just kind of a tight dressing that attaches to the skin. And it's going to put a constant gentle pull on this broken leg. And I know you're thinking, well, won't that hurt? But I'm not saying it doesn't hurt at all, but it actually makes it feel better because it's kind of pulling it real slowly and gradually back to where it needs to be, because a lot of times with a broken hip, it gets out of alignment. So that's why we use Bucks traction. Like I said, it's usually real short term for a day or two while we're waiting for someone to have their hip surgery. Head halter is shown right here. We might use this like if someone had a neck injury and we don't want there to be any compression of the nerves in the spinal cord, or the cervical spinal cord right here in the neck, so we put them in head halter traction. And again, this is a type of skin traction, meaning we didn't surgically attach pins into any bony areas. Wrestle traction is I've never really seen wrestle traction, but it's a type of skin traction. It's a little more complicated than Bucks traction, but similar principle. It has the Bucks traction with this little added component here. So then we have skeletal traction. Skeletal traction requires surgical placement, and because it's surgically placed and there's pins here, you can see the pins right here, we can use heavier weights. Vink tongs and a halo vest are two common forms of skeletal traction. And again, this requires surgical placement, which is what is the main difference between the skin and the skeletal traction. good body alignment, making sure the weights hang freely, and careful pin care are